What are we going to talk about? We're going to talk about one of the most important topics in emergency medicine or urgent care. We're going to talk about headache. Let me give you some data and some facts. You know, I've hung around ACEP a long time. I was the national president, all that sort of thing. And we did look at this issue. 94% of all visits to the emergency department fall into one of 25 chief complaints. 10 of those 25 are neurological. I'm weak. I'm dizzy. I'm weak and dizzy. I'm weak and dizzy, and it started when I was 12. Okay, all those things actually do exist, but there are 10 chief complaints in that group that are all neurological. Of the 5 most common chief complaints in emergency medicine, 2 of them are neurological: low back pain and headache. Now, you may go days and not see a rupturing AAA, right? Is that a fair statement? You may go days before you don't see a primary aldosteronism, Conn's syndrome. But you aren't going to go an hour without seeing a headache patient. Is that right? How many people say they would see at least 2 headaches a shift? Yeah, okay, so pay attention here. What we've got to decide is what's causing this headache and what we don't want to miss. And I'll tell you right now, I probably don't do a CT scan in 1 in 100 headaches, something like that. Why? Because only about 1%, between 0.5% and 1% of headaches are actually a serious life-threatening condition. Everything else is what? Mostly a pain problem. And people come in and say, "Oh, doctor, it's the worst headache I've ever had." I said, on a scale of 1 to 10, what is it? They say a 12. I said, what don't you understand about 1 to 10? You know, it's unbelievable. It never changes. So what's the approach here? History. Take some real history. I see it all the time. You pick up a chart, and it says headache. And now, how high is your interest level? Not very high. The only thing works could be somebody with a headache and low back pain together, okay? And terminal fibromyalgia. Oh my God, awful, yeah. John Edmeades is a genius. John was a good friend. Unfortunately, he died a couple years ago. He was the chair at the University of Toronto in neurology, and he's the rarest animal in captivity. He was a useful neurologist. You know, and he did something which nobody else had ever done. He looked at every case of subarachnoid hemorrhage in the Ontario health plan. You know, the Canadians are smarter than us. They don't have a national health system. It's by province. We'd be better off if we did it by state. But he looked at everyone in Ontario for 20 years and asked this question: what actually makes a difference when you're talking to a patient to decide if they're sick or not? Number 1 is onset and severity. Here's the rule. You are 16 times more likely, between 16 and 20 times more likely, to have a subarachnoid hemorrhage if it did come on like this. Bang. Here's the rule I use. If you went from sudden onset to maximum intensity in 1 minute, what do you have? Well, you've got to at least rule out a subarachnoid hemorrhage. You don't get a choice. Okay, that story, I don't care whether it's an 8 or a 9 or a 10 or a 12, it's the onset. Thank you. Next question. Did anybody in your family, like, bleed into your head? Yeah, we had 2 of those, but we're done now. Okay, I know what I'm looking for. Again, I'm an emergency doc. I'm ADD, ADHD. All right? If the history takes me more than 5 minutes, I'm bored now. Okay, move on. I got to do something else. If I wanted a continuous life of boredom, I'd have been an internist. I'm not. All right, I would have been. Shifting dullness. Oh my God. All right. Nausea and vomiting, although they might show some intensity, are almost never related because people with migraines get that. People with tension get that. All kinds of people get nausea and vomiting. On Edmead's scale, it's barely a blip. That doesn't mean that it's something you have to treat symptomatically, but it's not the key question. I gave you 2 key questions. That's what you got to think about here. But if they have another neurologic complaint, by the way, I had this terrible onset of pain and my arm doesn't move, whoops, we got a different question now. But that's rare. Think about it. Think about your last 500 headaches. Maybe you picked up a subarachnoid, but most of it wasn't. History of trauma, fever, hold on. Headache, severe, and fever, we got a different group of diseases to think about now. Fever is important. Fever, and you know, doctor, it hurts when I move my neck. All right, I'm concerned. Now, it may not be bacterial meningitis because that's relatively rare, but it could be viral. It could be something else. Do they have AIDS? Could it be fungal? I don't know, but when you've got a fever, think about it. Prior headache history is useful, but everybody thinks they have migraines. Everybody, right? If I actually divided up the waiting room and said, who here has a migraine or has had migraines, I'd probably get 70% of the hands. How many people wish they had a migraine so they could get Percodan? Oh, a lot of people raise their hand, you know. Understand, family history is of some importance, but it's tough to use. Let me give you a secret. I'm old. I hate computers, all right? I don't want to text anybody. I don't want to do any of this crap. I just don't want to, you know? Listen, the day they invent virtual sex, I hope I die. I just want to die. Physical exam is still key. Touch their head. I get residents all the time, they come in and say, you know, and I say, well, what do they got? I said, what did the head exam show? And they all go, exam? You mean like I have to touch them? I said, yes. Put your gloves on if they bother you and touch them. Because we see lots of complaints of headache, which are actually their sinuses. It could be their bad teeth. They might have inflammation of a nerve, greater occipital nerves. You can't believe the number of times I've gone in, palpated the greater occipital nerve, put a little injection in it, and they're better like that. I actually spent a lot of time studying all the nerves of the head. I can find, with a needle, I can find anything. If it's on this outside or in the teeth or something like that, I can make them happy. But you don't know that unless you examine them. If you present me a case, and I do not have a head and neck exam on the headache case, you're wrong. I flunk you. You should always examine the part that hurts. Obviously, vital signs, and in that, obviously, temperature is important. The eye exam itself should be done, and visual acuity, I don't expect you to do visual acuity on all these patients unless they complain about it. It's not useful. By the way, how many people ever have an eye complaint, just an eye complaint, brought in and put in the chair, and the nursing staff hasn't done a visual acuity? That's just wrong. We always check the output of the organ they're complaining about. You wouldn't have a heart patient where you didn't have the pulse and the blood pressure. Why? Because it's the output of that organ. If there's an eye complaint, visual acuity. I think the fundoscopic examination is being lost, but I want you to Google something for me. Go home, Google spontaneous venous pulsations. If you can't recognize spontaneous venous pulsations, I don't know what you're doing. In 95% of young adults, basically, by the way, old adults is always 10 years older than I am. That's just the way it is. But You look in the eye for spontaneous venous pulsations. If you see that, they do not have increased intracranial pressure, and that's about 100%. Virtually 100%. Now, if you don't see it, it doesn't mean they have increased pressure, but you've got to think about it. 95% of adults in the sitting up position will have spontaneous venous pulsations. Pay attention. And by the way, while you're looking at the head, you're always looking to see if one of the causes of pain is glaucoma. So the eye exam on headache is important, and it's useful, and the reasonable neurologic exam, including walking the patient, should be recorded. Henry's Law. There are 3 things of importance that the neuro exam centers around. Hear them talk, watch them walk, look at their eyes. You can tell about 90% of the nervous system by those 3 things. And again, the residents walk in, they say, well, we did a neuro exam. I said, oh, what was their gait like? And then they turn around and shuffle back to the room because they haven't done it. Grow up. By the way, all this stuff is in my book, Neurologic Emergencies, which is outside at the desk. My children will pass through the audience selling them, of course. But here's a little chart that we include in this course, which, as far as I'm concerned, is only very vague. But understand that there are reasons to get a CT scan and to do an LP. I like LPs. I do them all the time, or I did. I probably did 1,000 in my career. And once I discovered Versed, life became easy. Because you always have that person, I know you're going to tell this story, well, they didn't want an LP, right? Standard crap. I just don't even give them, what I say is, would you like to be blotto? How about if I blow your brain so you don't feel anything? Yeah, okay, I'll go with that. I've had nobody refuse me since I said I'll blow your brain and make you happy. Yep, little of that, they go, put the needle in, not a problem. I always love it when they wake up and say, when are you going to start, doctor? You know, there's nothing like cerebral spinal fluid. It's like gold. You can look at it. You can feel it. You can put it under a microscope. You can grow it. Get a little cerebral spinal fluid sometimes. It's good for what ails you. Now, people will argue that is the new CAT scanner so good that it won't miss a subarachnoid? Depends what you mean by good. What is the acceptable miss rate? You realize we're the only country in the world that doesn't discuss on every disease entity what is the acceptable miss rate. And we still miss maybe 1 in 100 if we don't do the LP and the CT, initial CT on a level 4 scanner is normal. Maybe 1 in 100. Let me ask a question. Would any of you fly on an airline that had a 1 in 100 bad landing rate? Just for discussion. If you wouldn't, then don't subject the patient to that. What are some of the things they talk about here? Obviously, trauma. And if they have a positive neurologic sign and trauma, they get a scan. That's just it. And by the way, the first thing I do is, I talk to them. I go down to their toes, go like that. If I have an upgoing toe, bang. Do I have to do anything else at that moment in time? No. I have only one question. Does man with knife want to work on this person? Yes or no? People always say, we make fun about saying, well, God, that's not brain surgery. You know what? Trauma brain surgery is pretty easy. We either open it or we don't. It's either bed rest and bathroom privileges, or we open your skull. You know, that's kind of it. It's not very hard to think about. Confusion, sudden onset of confusion in anybody, you have to decide, is this encephalopathy? Is this from a meningitis, an encephalitis, a mass lesion? What's causing that? So understand that that really needs to be worked out. Get a real good examination of what's happening on these things. Obviously, we have sinus headaches. What time is it? Oh, my God. We have sinus headaches. We have cluster headaches, tension headaches. By the way, we show you in this book areas where it may be involved. You don't know you have sinus headaches unless you feel the sinuses. Cluster headaches are relatively severe. They tend to come on over hours. They tend to be on one side, and they tend to be related to a time of the year. I've had lots of people the nurses thought were crocs, right? He's been in 3 times in this month with a headache. Well, it just so happens in that season of the year, because of their allergic condition, they did. So I examined them, gave them a burst of steroids, and you know what? They didn't come back during that period of time. Now, they may not have come back because they didn't get Percodan, but, you know, the patients actually get better with this. What are migraine characteristics? 3 times as often in females. No migraine comes on at age 50. Migraines come on in your teenage years, maybe up to 30, but almost never older than that. Migraine is something which comes on, lasts, you have triggers, you figure it out. These are the patients who will really tell you the thing started to throb, even in a dark room it got bad, I can usually handle it, and now I'm in. Positive family history in about 80%. Nobody knows exactly what that means, by the way, because this is a behavior which we learn, which we've been taught. Nausea, vomiting, photophobia. Common migraine does not have an aura. Classic migraine has an aura. The toughest cases you will ever have when somebody says, I went blind in this eye, now I feel okay, except I got this terrible headache. What is that? Is that a stroke? Is that a TIA? No, that's probably an aura of migraine. We have abdominal auras. We have all kinds of auras that can go with migraine, but patients learn what these are pretty quickly. What about treatment? I am a big believer of heading first to prochlorperazine. I wrote the chapter in Rosen on headache, and I pulled all this data, and you know what? The biggest problem in most of these patients is the nausea, the sickness of the stomach, all these things which Compazine, the standard name, the trade name, takes care of. That's the drug I go to first. The other thing, with an experienced migraine patient who's been worked up, somebody spent a lot of money on them, I'll walk into the room and say, what works? Why not? Right? They've been through the process, and they say, you know, dihydroergotamine knocks it out like that. Baby, you got it. Joom. And then I'll come back in and see what I got to do. Do I occasionally have to use rescue narcotics? Yeah, I'm like all the rest of you. But I don't feel bad about that, but I don't start out with that. I start out with other medications, and you know what? In most cases, I can make them feel better. Now, I want to make sure I got somebody to drive them home and all that kind of stuff, but true migraine patients do respond to other medications, and most of them should be on some sort of prophylactic system. I never write those. That should be the family doc or the neurologist who does that. I don't start that from the emergency department. What about cluster? Again, cluster comes at certain times, at certain ages. It tends to be unilateral. It tends to involve the 5th cranial nerve. If you're going to know some anatomy, know the anatomy of the 3 branches of the 5th cranial nerve. You ought to know where they pass out of the head. You ought to know what areas they involve, and you ought to know how we can go back after them. And I'll talk to you about this because when we come to treatment of people with cluster, treatment with oxygen, maybe it works. You got to remember, you're already saturated with oxygen. You got plenty of it floating around. A technique you should learn to do is anesthetizing the sphenopalatine ganglion, which you do with cotton balls or swabs. Put them in lidocaine or bupivacaine, which is better. I don't even know why we have plain lidocaine anymore. I'm not sure it has a use. Take it, you put it down the back of the nose, back to where the sphenopalatine ganglion exists. You let them sit with that in there for about 10 minutes, and they'll come out and say, it's gone. We can go home. And this is knowing the anatomy, knowing the type of disease process from the history, and it works. You should know how to do that. Headache is one of those disease entities you should be expert at. Why? Because you see so much of it. So you ought to know what to do about tension headaches. This is the band, that sort of thing. When we talk about what are we going to do for treatment, it's dealer's choice. I know that you're tempted to give them Dilaudid or something like that. See if we can avoid not doing that for a while. Post-concussion headache, everything has changed. We talked about that the other day. They've got a post-concussive headache. They do not go back into the game. They are followed up. They do testing on these people now. And as far as you're concerned, the post-concussive syndrome is yet to be fully diagnosed. You see it in the emergency department, but it's going to go on for a period of time. CT scans can be obtained. I'm not sure they're that important. And a lot of people would say with a totally normal neurological examination, CT tells you nothing. The exam that they ought to get if this persists is an MRI. You see, we got into ordering CT scans because we had nothing else. We now have a better test. And by the way, even with normal MRIs, that doesn't mean at a micro level they haven't had damage. We need to respect that. And the psychobehavioral portions of this can continue for months. We don't know exactly where that is located, and quite frankly, we don't know what to do about it. Post-lumbar headaches, post-lumbar puncture headaches. Does it happen? Yep. Use a small needle. Use the new ones with the blunt ends. Go into the skin first with a number 11 blade, because those blunt ends don't go through the skin well. Then put that thing in there. How do you do this with big fat guys? Don't have them lay down, sit them up and bend them over and find the spots. When I was, many years ago, when I was a neurology resident, they only called me on the tough ones, and we had to actually take them to radiology and put in the needles. I don't think we have to do that much anymore. Understand this, you're not going to take them all the way down. But if you're going to be in there, take 3 or 4 tubes. Take an opening pressure, take a closing pressure, take the 3 or 4 tubes, and know what you're going to get in each tube. Because we've got to know whether they've cleared a bleed or not, and that is important. Idiopathic intracranial hypertension. These are people who come in who have lost venous pulsations. You'll notice there on the slide, what do they have? Papilledema. We used to get these patients all the time as neuroresidents. What would we do? Every couple of weeks they'd come in and we'd tap them down. How did we know when we took off enough? We'd sit them up and look in their eyes, and as soon as their pulsations came back, we said, okay, we'll see you the next time it comes up, and then they're prepared to have shunts done. And it's an amazing disease that once you've tapped them, people feel better. Subarachnoid hemorrhage, let's get at it right now. Large subarachnoids, that means a hemorrhage from a aneurysm greater than 5 millimeters. That's considered large. Now, some centers will coil those up to about 6. Above 6, they tend to take them to surgery, and that difference is huge. The difference between opening your head and not opening your head is a huge decision. So what you got to do is find it. If it's bled, decide if we're going to coil it or clip it. Those are the differences. But in those cases, once you found what you need to talk to the person who can make that decision to take them to surgery. By the way, it's a 50% mortality, and if you bleed, there's a 50, let's say they bled. They come in, they're now pretty much okay. They have a 50% chance, 60% chance of rebleeding in the next 7 days. You realize you do more good with this disease than you do with every cancer you ever diagnosed. You actually prolong people in a functional state. This is important. Blood pressure control, by the way, is tremendously controversial. The brain is telling the heart, give me blood, perfuse me. If you've decided to drop their blood pressure, you can make them worse. Blood pressure control is a tremendously controversial condition, thinking about it. We all know about the warning leak. By the way, the standard of care in emergency medicine is all patients have all made 2 visits to an emergency department before they're diagnosed. Because when they get a small bleed, you don't know what they had. And now you're not quite sure, this, that, and another thing. Think about it. It happens. We're going to move on for just a second here. Xanthochromia. Look at the blood in those tubes. What does that mean? Well, I do a red count. I do a count in the first tube and in the 4th tube. Is it getting better or worse? The data on this is not good. But you got to have something. If they go from a little red cells to nothing, they probably have not bled. That's probably your technique in getting the thing done. And lastly, ventricular shunt headaches. Whenever you see somebody who has a ventricular shunt, now you will see those people, kids who had tumors, that sort of thing. Check the shunt, feel it, pump it. You can actually, with a Hakim valve, push on it and actually pump that fluid down back into their abdomen or wherever the end of the shunt goes. It can be done, but shunt headaches, sit them up, look at their eyes. Venous pulsations, yes or no? No pulsations, they're headed for a bad problem. So you call the place where they put in the shunt, say, I'm sending you this patient, I've tried to pump them down, but these are the kind of kids that can go in 12 hours from fine to Gorks. And so pay attention whenever they have a shunt in place. All right, ladies and gentlemen, this is one of those topics you need to know about. I think we're set now for a break, right? Take a break for about 15 minutes. Thank you very much.